First of all, a very, very warm welcome and a happy evening to all of you who've joined with us today for the second part of this webinar. So in the first part, we did some basics on diagnosis. So today we are going to jump into the management of binocular vision anomalies. And to begin with, I do not have any financial disclosures at this moment. So today what we're going to be doing is an overview of management to binocular vision. We are going to look at the sequential management approach, of course, through case scenarios. And I'm going to be using the same cases that we took in the first part. So in the first part, we did the diagnosis of 3 cases. And for the same cases, we're going to look at how we will be providing management through vision therapy. And I have made it a point today to just stick on to the very, very basics to manage, especially at the primary eye care level, because I know that not all of us have the infrastructure and sophisticated equipment and tool. But I have some very interesting facts to share as how, especially in the post-COVID era, we can utilize a lot of strategies, especially in the field of binocular vision and vision therapy, to thrive. And I'm going to be using evidence-based practice throughout my talk to just kind of, pinpoint the management as why we chose to manage the way that we chose to manage the patients. And of course, this is the textbook that if any of you want to go and understand the basics, please feel free to go and look into this book. And I think we've got a lot of requests after the last webinar that some of you were not able to kind of join for the first part. And, so there could be few of you who just directly joined for the second part. So especially for the benefit of those of you who directly joined, I'm just going to summarize very quickly over the next 5 minutes what we saw in the first part. So in the first part, we discussed about what is actually vision. Okay, so beyond 6x6 or 20x20, what is actually vision? So we discussed about the importance of accurate fixations, accurate vergence and accommodation, and then oculomotor movements, your saccades and pursuits, all these coming into the picture to really derive meaning from whatever that we see. So if I have to just describe vision, it's in one line, then it's the process of deriving meaning from what we see rather than just seeing. And this becomes even more important in the world of binocular vision because this is the pyramid that I use very often to kind of conceptualize how a primary eye care practitioner should look at binocular vision. And so the base of the pyramid is your comprehensive eye examination, and then your binocular vision comes next, which is given the terminology of visual efficiency, and then comes your other specialized testing like reading test, eye movements and oculomotor testing, and the last one is the visual information processing. So again, just to kind of emphasize that appropriate refractive testing and correction is the key to the pyramid, because if we fail to provide a proper refractive correction to the patient as the first step of management, then whatever you do may not really address the patient's visual issues or complaints, or even if you provide vision therapy for that matter, it may not sustain over a period of time. And the findings that you derive from every part of this pyramid is going to provide you insights into how you can use vision therapy to help the patient. So we also saw last webinar that the prevalence of non-strabismic binocular vision issues are as high as 31%. And if you have to keep in mind the most important conditions, then remember that it's convergence insufficiency, which is about 16% prevalent, and accommodative infacility, which is about 11% prevalent, especially among school children aged 7 to 17 years. And a quick recap. So we did discuss about refractive error correction, how we should use binocular balancing and refraction, to provide the appropriate refractive correction strategies. And also in the assessment process, we discussed about the near point of convergence, phoria, near point of accommodation, MEM retinoscopy, and accommodative facility testing as the key procedures to really, diagnose and start your management aspects. And based on the request from many of you, we are going to even make the part 1 webinar available so that you can actually watch the 2 parts together to gain the maximum understanding. And of course, when we do these testing, we should also know what is really expected out of these testing. And so what is really normal? These are the normative values that we proposed based on the existing literature and also based on the normative data that we collected from the Indian population. So all put together is here. When we go through each and every case, we'll just get back to this data as and when required. And then, so moving on to the conceptual framework, which is like super important before we really jump into the diagnosis, we have to make sure that we get the symptoms right, we get the refraction right, get the basic assessment done, which includes your 4EI, NPC, NPA, MEM. And then if you are not able to kind of come to a conclusion at this point, look at additional procedures where if you want to do your voyage delayed and then repeat these key testing and then move ahead with cyclorefraction as and when required. So this is the conceptual framework that we discussed in detail in the last webinar. And remember this, always before we diagnose that somebody has a convergence issue, we always make sure that accommodation is normal, because the monocular inputs drive to the binocular inputs. And so if there is something abnormal with accommodation, that is going to impact Vergence for sure. And because, as I said, get the history right. Okay, so I'm going to dive a little bit deep into what, as a primary eye care practitioner, you have to make sure to rule out before you jump into saying I start providing vision therapy, because more often we are starting to see these kind of hidden systemic diseases or neurological dysfunctions impacting accommodation and Vergence. So it's always important to know the fundamentals. So as we know, in accommodation, any kind of your cholinergic drugs, the list is here, can actually impact accommodation, and even like psychogenic ailments. And in adults especially, I have a list of diseases listed here. Whenever you see a acute onset of accommodative dysfunction or even accommodative dysfunctions for which you're not able to figure out, it's important to make sure that there are no viral infections or any of those diseases that I have listed here, including trigeminal neuralgia, multiple sclerosis, or myasthenia. In children especially, again, the list is here. Make sure that we've seen that there are children, who just land up with acute onset of accommodative insufficiency after an episode of measles, or children, especially girls in the pre-puberty, puberty ages of 12, 13 years, come with a lot of convergence and accommodation issues, especially due to a lot of, issues such as anemia. So make sure that you also dig a little deep into the underlying issue so that you co-manage the problems along with the general physician or a pediatrician, and not just, think that vision therapy alone will take care of the problem. And again, a list of neuro-ophthalmic issues, especially any kind of injury to the craniocervical region, because as we know that the sympathetic pathway runs through the cervical region, it's important that there is no injury as such in general, overall to the head, or any kind of injury to the craniocervical region. And this is a list of drugs. So usually we print out the list of drugs and put it in the clinic. And then in case if a patient says that he is on a specific drug and you're really not sure, then you can take a look at this list and then see if any of these drugs is on the patient's list, and that can impact accommodation. Next, moving on to Vergence dysfunction, very, very similar kind of a list, but here it's not as much as the list that I showed before. But here I would kind of, request your attention into certain factors such as a newly acquired fourth nerve palsy due to a vascular or infectious etiology, a closed head trauma, and any kind of a vertical gaze palsies as in Paranoid syndrome. So if you see an associated eye movement issues or any kind of abnormality which you are not able to explain, it's very important to co-manage the problems. Okay, so that's what is the message that I want to drive through this whole list of causes of accommodation and Vergence dysfunctions. And then if you have made sure that there are generally, okay, 80% of the time, usually you won't have nothing major underlying a non-strabismic binocular vision problem. But it's always important to, to ensure that you are not missing anything from the ethical standpoint. And so this is the sequential management approach. Now that you've gone ahead and then you diagnose the condition and you want to start your management, then this is the very simple framework, which is make sure that you take care of the refraction, give the appropriate refractive correction to the subject. And if you are prescribing a new refractive correction, make sure you wait at least 6 to 8 weeks before you start any therapy. So ideally, you will have to reassess the patient after a new refractive correction is prescribed. And the second thing is added lenses. So as we discussed last time, I'm going to talk a little bit more deeper about this. If a patient needs any plus lenses, especially for near, then you will have to go ahead and prescribe that as you would do in your accommodative esotropia, your near bifocal. Same thing applies to your accommodative insufficiency or ill-sustained accommodation. Then the next aspect is your vision therapy. Okay, so once you make sure, yes, I've done the glasses, I've done the near plus if required, now I can move on to my vision therapy. Let's move ahead with the cases for the day. So this is, most of you attended the last webinar, you're very familiar with these cases. So we did see about this 13-year-old school student who had blurred vision associated with reading, and the child had undergone all eye examination and visual acuity normal, refraction normal, so nothing as such very significant for this patient. So you move ahead and then you start your preliminary assessment. And so in the preliminary assessment, this is what comes up. Okay, so there is no significant refraction as we already discussed. And then you see that the patient is orthophoric for distance and a very small esophoria at near. And the near points of accommodation is as shown here. And then you also do your dynamic retinoscopy and you get a +2 diopter lag of accommodation in both the eyes, right eye and left eye. And your near point of convergence is 15 centimeters. Okay, so this is the basic data that we have with us right now. And as I go ahead with the case and I ask you any further questions, please feel free to go and type in your chat box, your answers, and we will take a look at it. Okay. So generally, we'll follow this approach. So remember the framework. So we said first take care of refraction. Refraction is normal. Then looking into the phoria, yes, it's very much within the physiological limits. But there are two parameters that are kind of abnormal at this point. The basic parameters. The number one is near point of convergence, and number two is near point of accommodation. So we did discuss this. Okay. So anytime you see an accommodation and a convergence problem kind of together, you always sort out the accommodation issue first. So here we'll have to make sure that the accommodation is normal. So we calculate what is the amplitude of accommodation for this patient. I mean, what is the measured amplitude of accommodation, and you have 5 diopters. Okay, but what is expected for the age? Okay, so what is expected, just whatever that you feel is expected, just type in the chat box. But we did discuss that use the minimum expected formula for Hofstadter's, which is 15 minus 0.25 into age. So if you really quickly calculate 15 minus 0.25 into 13, and just keep typing in your answers. Let's see who's the fastest finger that gets the answers. So 15 minus 0.25 into 13 is what is expected. So you have to look at whatever that you have measured, does it match with whatever that is expected for the patient? Okay, so I assume that you guys are keep giving answers, and the expected answer is 11.75 diopters. Okay, So look at the gross discrepancy in this case. The patient has just 5 diopters, whereas he's expected to have about 12 diopters. There's about 7 diopter discrepancy. So we discussed last time that anything lesser than 2 diopters is something of, something abnormal, and you need to really consider treating it. Okay, so this patient really has 7 diopters lesser than what is required. So we have to now start managing this patient. So what is the diagnosis of this particular case, where we find that the accommodative amplitudes are lesser than expected for the age. So subject is only 13 years old, not presbyopic, and young child, accommodative amplitudes are very poor. So just if I have to look into your chat box, I guess somebody is typing in accommodation insufficiency. Yes, this patient has accommodation insufficiency. And what should we do now? Okay, so just pay a little bit close attention to this. There are 2 standard ways in which you can decide about how much addition to prescribe, especially in the pre-presbyopic age. Okay, because generally we prescribe addition only for presbyopia, and you have your Duane's-Donders calculation or age-based calculation for addition prescription when it is presbyopia. But now we are talking about a young child. So how should we go about doing? There's 2 standard methods. The first is based on your NRA and PRA. So as we discussed last time, NRA is basically your negative relative accommodation, where you put plus lenses in 0.25 diopter steps binocularly. So you keep adding plus lenses binocularly until the patient reports a sustained blur at 40 centimeters. The near target is kept at 40 centimeters. The patient is looking at the near target. You keep adding plus lenses, and the patient says, stop it, I'm seeing it blurred, you stop there. Now PRA is just the reverse, where you start putting in minus lenses, and then you just take an arithmetic average of the 2. So in this child, the child says plus 2.5. Until you add plus 2.5, child is seeing the near target clearly. Whereas when you put minus lenses, even with half a diopter of minus 0.5, like patient says, it's completely blurred. So you take an average of these 2. So 2.5 minus 0.5 is 2. Divided by 2 is basically 1. So 1 plus 1 is something that you need to really consider as the minimum addition, or at least as the starting point. The second method is a much more simpler method, which is to use your MEM retinoscopy, your dynamic retinoscopy. So if the patient has a distance refraction or subjective acceptance, you put that in the trial frame. If there is no refractive error, then just quickly scope at near at 40 centimeters. So patient is looking at the near target, and then you are doing your retinoscopy, and then you are putting plus lenses to neutralize the lag of accommodation. You have to do it as quickly as possible to make sure that the accommodation response is not, the patient is not getting adapted to the target. Now, after you finish doing the procedure, you just have to subtract the normal values from whatever you get. So as we saw, anything in the range of plus 0.25 to plus 0.75 diopters is the expected lag of accommodation at near. I usually take the midpoint, which is plus 0.5. Subtract plus 0.5 from this, the starting point is plus 1. Now, I usually, if you see, I've highlighted this in red. The reason is, the post-COVID world, you might have to reduce the number of procedures that you do on the patient. You have to look at doing as much as non-invasive or not so close contact procedures. So I would recommend getting your MEM retinoscopy done over the NRA and PRA for 2 reasons. In NRA, PRA, you put the trial frame, you add lenses. So the whole process is disinfecting the entire stuff after you finish doing the procedure. The second reason is the time taken, and that itself is going to take, the NRA PRA itself will take about 5 to 6 minutes, and we are expecting to finish the patient less than 15 minutes. That's the standard, okay, right now. Okay, so you want to finish the procedure as quickly as possible. So you don't want to do anything that's going to take a lot of time. So within a minute or within 30 seconds, you're going to get the MEM retinoscopy done, and that's why I've highlighted that over the NRA PRA. So likewise, I've kind of highlighted procedures which I would kind of choose for the current situation. Of course, when situation gets back to normal, we get back to our our own way of working. Now, moving on to vision therapy. This is the standard protocol for vision therapy. So for all the cases, okay, be it accommodation or Vergence, usually we set 3 phases for training. The first phase is generally to normalize the amplitudes. Okay, so here the patient has accommodation issues, so we want to work on improving the accommodation amplitudes, and then parallelly you also work on the convergence, because you know that because accommodation is affected, convergence is also parallelly affected. Okay, in the phase 2 you move to training facility. So facility is all about looking at far, near, far, near. So you move on to the next difficult part of training, which is to train your accommodation and Vergence facility. The third phase is to integrate everything. Okay, so let's look at a sample protocol of how we actually do this. Okay, so this is a protocol that usually we follow. Again, look at those things which I have highlighted in red. I would prefer to stick on to these things again because of the time that's taken. And for example, in the phase 1, I've just put the hard chart and accommodative flippers because the patient can purchase these on their own. Okay, so in the VT kit, you can make these available. Make the patient get these stuff and then teach the patient with their own kit and let the patient take it back home. So you're not going to be actually engaging in any kind of in-office vision therapy for time being. I still have some guidelines if you want to do it, but then use procedures that are less time consuming in the office so the patient can take it home and then do it. So these are the 3 procedures I have written. The hard chart flippers, you can use it in the second phase also. And then in the third phase, I have written binocular therapy and computer orthoptics and flippers. Okay, so look at this. This is a computer orthoptics procedure where the patient will use the flippers and then the Landau C, the resolution task is given. So patient will have to look at where DC is facing and press the appropriate button. Okay, so this is a computer orthoptics binocs that you can use for accommodative facility training. And this is your loose lens rock. Like, in case if you want to get back to your clinics later at some point, you have the plus lenses and minus lenses arranged in order here. So what the patient does is, put the trial frame, you put prisms so that the patient now sees 2 images, put plus lens in one, minus lens in other. So patient will relax first, stimulate. Okay, so you're rocking between stimulating and relaxing. And that's the key to doing the loose lens rock. But as I told, you're going to stay away from this procedure because look at the number of items that are here. So the accommodative facility training is going to give you the same benefit as this. But of course, I'll recommend this for other reasons, when you are proceeding with therapy and want to move to difficult levels, then you can go ahead and increase your minus lenses as much as possible, especially in younger patients like this. You want to increase your minus lenses beyond 2 diopters that you use in the flippers. So, but let's hold on to this procedure for now. Then our usual favorite flipper exercises, and where you can give age appropriate targets and then use your flipper lenses and then flip between the plus and the minus side and then alternately clear it. And I would recommend all of us, anybody who is pre-presbyopic, definitely have a pair of flippers with you all the time in the office or even at home if it is possible, to keep engaging your facility, because of the increased prevalence of digital eye strain and all accommodation issues coming up. I'll just show you some evidence later. And the heart chart. So this is the heart chart, which has a large set of larger size letters at distance. You put it at 3 meters, and then the patient holds a small size letters at close distance, and patient keeps fixating between the far and the near, making sure that whatever they fixate is clear. This is a very simple procedure that you can advise every children and adults to do it at home. I kind of make sure that my kids at home, my niece, my nephew, everybody, they just simply use a newspaper at near and the calendar at distance, keep rocking between far and near, at least after every 45 minutes of their gadget use or homework or whatever it is. So this procedure actually kind of does the same thing as your 20-20-20 rule, where you tell the patient to take breaks after every 20 minutes, look something at far off for 20 feet for 20 seconds. And now all of us being stuck indoors, of course, teaching procedures like this should also be part of visual hygiene measures. And that's why I'm recommending hard chart that you can advise it to all your patients. So see, any kind of accommodative dysfunction, the three procedures that I mentioned right now, your hard chart, your accommodative flippers, your visual hygiene, and anything like your loose lens drop, these are the standard protocol, okay? Be it accommodative insufficiency, accommodative infacility, accommodative spasm, the procedures are same. So if you learn these procedures, you can use it in any kind of, dysfunction. The key is, how do you want to increase the difficulty? What should you advise the patient to spend more time in? Now, in this case, the patient has got an insufficiency of accommodation. So patient is going to have difficulty with minus lenses more than plus lenses. So you have to now ensure that patient does more with minus lenses and stimulate their accommodation. And even with hard chart, your task is to make the patient see clear as close as possible. So start at 40 centimeters. As the day progresses, the patient has to bring this near target as close as possible and still be able to see it clear. Whereas in case of accommodative infacility, you will focus at both distance and near equally. You will focus more at plus and minus lenses equally. So that's all the difference, like how much you want to emphasize and which side of the, the plus or minus you want to emphasize depends upon the diagnosis. Now, why do I say that, go ahead and give plus lenses? Because many practitioners have asked me, like, is prescribing plus lenses to young children, is it not bad? Does it weaken the accommodation system? And so what I really say is, I am not advocating for prescribing plus lenses on a constant basis. I'm telling you, you have to actually enable the accommodation system to work to begin with first. So plus lenses are the only way to get rid of this whole accommodation insufficiency that you're seeing here, like a 13-year-old child with 7 diopters of discrepancy between the expected and the measured amplitudes. Now, where would you go? You can't even do vision therapy for this child. So you have to start with plus lenses. Then you have to add vision therapy on top of it, and then slowly wean away the plus lenses. So why would I say that? Okay, there are very good studies. You can go ahead and look at these studies where people have looked at are reading on plus lenses better or exercise is better. Of course, the sample sizes of these studies are really very less. And in this particular study, they have not really discussed anything about the severity of the accommodative insufficiency. So in this study, the children had almost significant improvement with both, okay, with both vision therapy as well as with low plus lenses, okay. And this is another paper, which is like a very early paper that we use as kind of like foundation for training accommodation. Doesn't actually improve even accommodative amplitudes, okay. So if the accommodative amplitudes are borderline, okay, not very severe, definitely you can directly start vision therapy. And then look at this, they have given facility training to a group of children. They have just given sham treatment, a placebo treatment to another group. And children who were given the actual accommodative facility training improved in their accommodative amplitudes as well as the relative accommodation. So it has a real effect. So vision therapy or accommodative facility training does have a real effect. And I have seen it in all my patients, my own self. And, so definitely you can, I'm kind of emphasizing this time and again because this era you're going to see a lot of accommodative dysfunction, okay, I bet you. So that's why I'm just kind of preparing your mind that the importance of vision therapy, accommodative facility training is all going to become super important, okay. Next, okay, I now decide to go ahead with reading lenses, plus lenses for this particular child. What should I really give? I usually give the lowest possible for 2 reasons. Number one, as we know, you don't want to really kind of, take care of all the accommodation that the child requires through the plus lenses, because if you're going to do that, the system is going to get adapted to that plus lenses, and you're not really exercising. So the second thing is, you also want to give some indirect vision therapy. So if the child needs say +2, you just give whatever is the least possible, so that there is some amount of blur, some amount of residual blur that's going to keep triggering the accommodative system, but that blur is going to be within the ability of the system to actually accommodate. Without giving any plus lenses, if you want to provide vision therapy, the blur limits are beyond the thresholds for the child to really accommodate. But you're going to facilitate with a very low addition, then the child now is able to do your vision therapy. So prescribe low addition to avoid the effects of adaptation, and also the low plus will serve as an indirect vision therapy to stimulate accommodation. So low plus lenses are recommended. This is the evidence that we use in our practice to treat accommodative insufficiency. And so if you have any doubts with respect to that first case, you just can type in the chat box and we'll take the questions later. Moving on with our second case, again, the case that we discussed in the last webinar, 10-year-old school-going kid, lots of eye strain, again, insignificant refractive error. And then look at it, patient has large exophoria at near, normal near points of accommodation. So again, we are not dealing with accommodative issue for this particular child. Receded near point of convergence with accommodative target, much more with pen light and red green filter. So we discussed again last time that the importance of using a dissociated target like your pen light and red green in children. Okay, so look at the difference. It's definitely more than 5 centimeters. So it's very, very suggestive of, you know, convergence issues. And so NPC receded again the same. I kind of use the same sequential approach, the framework, so that it kind of gets into your mind. So next time when you see a patient, you will just keep, you know, thinking in this line. And so NPC and phoria are abnormal in this particular case. And so now that we know this is a patient with convergence insufficiency, I'm going to ask you to just type in the chat box as what is your preferred treatment for this patient. Okay, I'm just going to wait for 10 to 15 seconds to just see what you're going to type in the chat box. Okay, just type in the chat box. As now that we know this is convergence insufficiency, what are you going to really do for this patient? Okay. So a lot of you are saying Brock string and some convergence exercises. Good. Some of you have asked questions about what is PLRG. PLRG stands for pen light and red green filter. So when the part 1 webinar becomes available, go and look into this procedure. It's a very, very nice and a very important procedure to diagnose convergence insufficiency. Okay, doing your near point of convergence with the pen light and red green filter. That's what is PLRG. Okay. And so yes, you say Brock string. I agree with you. So this is a preferred clinical practice survey that was done almost a decade back in India. Okay, and this study said that maybe at that time, pencil push-up exercises was the most common line of treatment offered by ophthalmologists, followed by synaptophore exercises. And then after which, you know, many studies came in, but this is one study that I want you to go and read. Anybody who wants to practice vision therapy should be very, very familiar with this particular study, which is currently the only randomized controlled trial that's there, you know, in this particular field, where they looked at you know, your in-office vision therapy, which is also some people call it orthoptics, how efficient it is compared to your pencil push-ups in the treatment of convergence insufficiency. And what did these authors find? They found magnificent results. Okay, they found that look at these graphs. Okay, so look at these graphs here. Okay, so in-office vision therapy provided the maximum improvement, followed by your computer and home-based exercises, computer orthoptics and home-based exercises. And your pencil push-ups was as similar to placebo therapy. Okay, there are many reasons why it didn't work. We'll take it in another discussion, but the key point here is so vision therapy is not something that you know, you give to the patient. It is something that is done by the patient, something where the patient internalizes that the system is changing. Okay, in fact, I do another lecture where I talk about the mechanisms that drives this whole thing, the accommodation and Vergence mechanisms, how it is integrated into the neural system. What are all the regions in your cortex that actually responds to the training that you are giving? So it's not at the level of your eyes, it's not at the level of just your extraocular muscles, it's basically at the level of your cortex. Okay, so you are imbibing these changes through your vision therapy at a much higher and deeper level. And when you're doing this in-office vision therapy, what really happens is this. Okay, say when the patient does the therapy, the patient has to understand the blur, the double vision, the changing of the target size. Okay, there are a lot of feedback cues that the patient gets. So when they do this computer orthoptics, or when they do these even your simple cat cards for that matter, when the cats become single and they come closer to you, they'll appear much smaller and they'll appear as if they're popping towards the patient. Now, these are all feedback cues that kinds of gets into the system and tells the patient that yes, I'm converging. Okay, and that is what is the fundamental aspect to improving accommodation and convergence. And in-office vision therapy, because you have the optometrist or the therapist who's going to advise the patient about what exactly they need to be seeing, or you have these computer orthoptics where the patient is getting these feedback mechanisms. Okay, that actually works much better than your pencil push-ups, and that's the only these feedback cues and the improvements that the patient is actually seeing are the keys to actually driving the improvement. Okay, and just go look into this paper. It gives you very nice annexures as how you should go ahead and administer therapies. Okay, so as everybody said rightly, Brock string. Okay, so Brock string, barrel cards, and your computer orthoptics. Computer orthoptics, why I'm mentioning again and again is because it has different levels, beginning from the most easy to tough levels. You can kind of keep increasing the levels as the patient keeps doing. And in a very tech savvy world like this, it becomes so easy for the patient to, not dependent on their practitioner, or they need not remember, I have to do this today, I have to do this tomorrow, whereas the computer sets in the targets for the patient. And that's the reason why worldwide computer orthoptics has taken in a very, very important stage in vision therapy. Okay, so in the first stage, just look at the headers. The first stage is all about training gross convergence. In the second stage, it's about training the ramp vergence. Okay, ramp vergence is nothing but training step vergence. So you're improving the vergence amplitudes. And in the third phase, it's about building the facility. Okay, so you're improving the jump vergence, and that is how you keep adding procedures. You can use your Brock string actually for all the three stages. How you want to use it is what you have to learn. So in the first stage, you just use the Brock string to teach the patient about physiological diplopia. In the second stage, you use the Brock string to help the patient fixate from one beat to another, from converge to from converging to diverging, from converging to diverging, and you can position the beats accordingly so that you can increase or decrease the difficulty of the task. When you're doing jump vergence, you can keep the beats positioned really far off. Okay, one very close, one very far, and you can do your jump vergence training. So what is important is to know how I should modify the procedure. You can use the same technique, but just modify the procedure. Okay, so that's what is the key. So just to re-emphasize the steps, the first step is to increase gross convergence, improve gross convergence. The second step is to increase the step vergence or ramp vergence. The third phase is to improve your vergence facility. So you keep adding procedures such a way that all this improves, and do not forget to add accommodation to all the steps. Okay, because your binocular vision doesn't work only with one system. Accommodation also needs to be trained in parallel. Okay, so as you see here, these are all some of the free space fusion cards that we use to train, and then your barrel cards that you use to help the patient converge, and the computer orthoptics where you can use random dot stereograms to train. So for this particular child, we gave 10 sessions of in-office therapy. Usually we give 45 minutes per session, consecutive days. Okay. Again, I'm going to propose some modifications as how you can handle this in the post-COVID era. So this is what we did to this patient. We did 10 hours, okay, 45 minutes, consecutively placed. And very important to document the improvements that you see. Okay, so this is the patient. As you see here, all parameters improved. Okay, the exophoria came under good control. NPC improved so very well. The positive visual vergence amplitudes improved, and accommodative facility also, as you see here, improved so very well. Okay, so this is very important to document what is pre VT parameter, what is post VT parameter. You have to document it in the medical records, in your vision therapy, whatever records that you've got, and you also have to share this with the patient. This is very important to let the patient know that all their efforts have kind of helped them to improve. Okay. So patient was super happy, and these are your super happy patients actually, because convergence insufficiency, as I told, with about 16% of prevalence, you are going to see more and more patients, okay, with convergence insufficiency. So it's with these simple techniques, you can actually treat these patients so very easily, okay. And then the next case, the third case that we saw last time was this 32-year-old software professional who came with intermittent blurring associated with computer use. Okay, so this is very, very common among all the technology users, including you, me, everybody. And again, no significant refraction for this patient. Okay, so we did discuss about this case that NPC is normal, NPA is normal, fraction findings are all fine, but accommodation facility is very reduced. Okay, so if you see here, patient has about 2 cycles per minute monocularly and just 1 cycle per minute binocularly, difficulty with both plus and minus lenses. Okay, so this is a very, very typical case of accommodation in facility. Okay, so accommodative in facility cases where every other parameter is normal, but only accommodation facility is reduced. So what do you want to do for this patient? Just remember what we did for the very first case, and then just type your answers in the chat box, as if I have to ask you what techniques you will use to treat this accommodative in facility based on whatever we've discussed so far. Any name of procedures or whatever, just type into the chat box. Okay. Okay, good. Hard chart, accommodative flippers, you're right. Okay, same thing. So whatever 3 procedures we discussed in the very first case of accommodative insufficiency is the same thing that you will do for this patient also. But as I already told you, here you will have to focus on both the plus and the minus lenses. You will have to focus, you will have to teach the patient to emphasize, to make sure that they see clearly at both far and near. But the same hard chart, same accommodative flippers, same computer orthoptics, you can just rock it. Okay. Now, the take-home message from all these 3 cases, again, I'm just kind of emphasizing certain things time and again, which is to make sure that you prescribe the appropriate optical correction. Make sure that your diagnosis is very, very, very clear. You are not missing anything at the background, any accommodative insufficiency. Remember the list I told you. Again, put down your goals for vision therapy. This is what I want to do in phase 1. This is what I want to do in phase 2. This is what I want to do in phase 3. So sequentially plan it. Many times, this is the mistake that I see that many of us do, okay, which is bombard the patient with too many things. Okay, imagine you go to a doctor for something and the doctor gives you 15 pills, okay, and you will be feeling so very giddy, right? That's what we do. We prescribe like 7 techniques, 8 techniques, and then patient does not do even one. Many of the reasons for poor compliance is overloading the patient. Okay, don't do that. Start it very simple, keep it very simple. Just do 1 or 2 things at a time. Okay, and that's very important. Next, move from easy to difficult. Many times in the enthusiasm to show all that we know, we kind of put the patient with the toughest thing to begin with. For example, if the same first case of accommodative insufficiency, if you're going to give a +2, -2 flippers on the very first day, child is going to run off. You have to only start, as I told you, prescribe low addition lenses, then start with hard shot at a manageable distance. After a couple of days, use low power accommodative flippers. You have to modify it here. You have to use, say, something like +2 is fine, because the patient may not have difficulty with plus lenses in accommodative insufficiency. The minus side, you have to reduce it. You have to custom make your flippers. Usually we do +1, -1, +1.5, -1.5, and +2, -2. So you can choose the lowest and then give it to the patient. Never ever show, throw tough thing to the patient to begin with. The next thing, as I told you, be aware of whatever feedback cues that the patient needs to learn. So as I told you, in the randomized control trial, the CITT, Convergence Insufficiency Treatment Trial, they found in-office vision therapy to work well. The reason is because the optometrist was available to the patient to tell the patient what is double vision, what really happens when you suppress one eye, what is this when the targets kind of merge together, the shimmer effect that you see, which is what is called luster. As I told you in your CAD card, when the cats fuse, they become small and they come closer to you, which is what we call the small in, large out, or the silo effect. They float in front of you. So anytime you give a convergence technique to the patient, when the patient says, yes, I have converged, ask the patient to point out to the target. Okay, the target will be floating on top of whatever surface that they're working. Okay, that's called float. So all these feedback cues need to be taught the patient, and emphasize that the VT is not done to the patient, but it is done by the patient. It's the patient who has to take the responsibility to internalize the process and do the technique. So this is the sequencing, which is taken from Leonard Press Applied Concepts in Vision Therapy. Start from monocular skills to biocular to binocular skills. Equalize the visual skills between the two eyes. Start from stereopsis training and then move to your flat fusion. And then, as I told you, start from larger targets, then go to smaller targets. And always in the phase 3, you should train jump vergence, you should train accommodative facility. So all the dynamics of training, which is accommodation and vergence, should come towards the end stage. And the last but not the least is loading the other sensory systems, okay, which is adding tasks such as putting the patient on a balance board while they do hard shot, adding an auditory cue to the task, where, you know, when the patient does the training, add timer that within this much timing you will have to finish this task. Okay, so loading both cognitive, your vestibular balance, your auditory system, all that is going to help the patient sustain the improvement. Okay, but don't bother about everything right now. If you want to start somewhere, remember the few key aspects that I discussed, which is start very easy, start very slow, and teach the important feedback cues to the patient. Okay. Okay. Now, this is a case that I didn't discuss last time, but I thought this is very, very essential to the current scenario. I am very sure, my intuition tells me that all of us are going to be seeing this kind of patients to the moment we just open our clinics. Okay, so that's why I'm just bringing in this case. It's an 8-year-old school-going kid. So the mother told me, like, you know, she started to notice the inward deviation of the eyes on and off very recently. Okay, we've just seen the child before 3 months. Child was completely normal, orthophoric, emmetropic, no previous history of glasses. Then we just, you know, did the assessment. We found that retinoscopy was highly varying. We did an open field auto refraction for this child. Okay, I'll tell you the results. Very interesting. And this child showed intermittent esotropia at near. Okay, when the child was asked to accommodate at like closer distances, the child was showing like kicking in with very small ESO. Then suddenly the eyes would go in and then will fix here. And then we have to tell the patient to blink multiple times, the child will become ortho. This was like very, very, you know, very scary and very curious also. And then the accommodative amplitudes were very normal. And then the patient, the child, you know, he said that whenever my eyes become crossed, of course, I see everything double. Okay. And visual acuity, whenever he blinks, the eyes are like straight, reading 6/9. The moment he just tries to focus, vision goes off to 6/80. And I'm going to ask you to just type in the poll. If such a child comes to you, what would you want to do? What do you want to do next? Just take 10 seconds and type in, because you're going to be seeing children and you know, teenagers like this for sure. The moment we just the lockdown gets ended, so we have to be prepared in facing these children. That's why I added this case. So just type in so that I will see in the chat box your comments. Okay, so I'm getting in the answers. People say atropine refraction. Yes, good. Cycloplegic. Yes, very, very nice. Okay, that's what we should do. And so because usually the patient, whenever the patient comes in, no, for the first visit, of course, you can just use your regular cycloplegic drugs, which is cyclopentolate or hometropine, whatever standard of practice that you use. You can just use that as the first resort. And if nothing happens, if the accommodation is not relaxed with that, then we can resort to atropine. Now, in this case, this was not like a manifest spasm, like it's just just kicking in. Cycloplegic refraction was done and we found +1. And I told you right before dilatation, when we did the auto refraction, the refraction was minus 5.5. Okay, so we just printed out the refraction also to both show it to the parent as well as the child, like, you know, to scare the child, like this is your reading. Okay, and I'll tell you the history as how he ended up with that prescription. And post refraction recheck visual acuity. So visual acuity was 6/6 in both the eyes. A very what I should say, relaxed moment for the patient and the parent. And intermittent ESO didn't go off that time, so we said, okay, let's do a PMT, let's just wait for until the cycloplegic effect settles. If things didn't go off, we might have to start atropine, but then, you know, luckily intermittent ESO disappeared in 3 days. This is like a fresh spasm that's just set in. And the history was this is May, so the school holidays, last May actually, school holidays had started. And gadget use continuously, like the mother was like 6 to 8 hours at a stretch. And after a week, this is what happened. Patient came in with accommodative spasm. And then after that, now that the child is scared, patient is scared, they're of course following all measures. And this is one of the CDC guidelines that we use in the clinics, WHO guidelines. Of course, we don't, this is the guideline for age group 8 to 10, because this child was 8 years, right? Where they say that the average time that kids spend is about 6 hours a day in front of a screen, almost, including television, your computer, laptop, iPad, everything, iPhone. And they say instead of that, ask them to do all this. But right now, what should we do? Big question. Okay, we have to discuss and see still what should be done, because now that all of us are glued indoors, I'm really sure that there is so much coming in. I've already started to get messages from my patients who have already been diagnosed with problems, that, you know, symptoms are coming back, accommodative symptoms especially. So visual hygiene is definitely a very, very important key aspect. Okay, so I would, though we can say it's very difficult, though we can say we are all very anxious, we have to really look at how to limit screen time. Okay, it's important to understand the consequences of gadget addiction, and awareness is the key. Awareness in the sense, not just awareness about the condition, or awareness about the consequence, but awareness in terms of how the parent can engage the child in terms of you know, distracting the child from gadgets and other activities to involve in. I completely agree as a parent and a practitioner that it's too very difficult to do this. Easy said than done, but there's no other go. We have to look at all aspects of terrace walking, terrace cycling, terrace jump rope, morning walking in the sun, whatever that is possible, like, you know, in the terrace, in the balcony, whatever that can be brought in, we need to bring in. Otherwise, we are going to see another I don't want to use the word epidemic or pandemic, but another surge of these accommodation issues, because this is the whole guidelines. Okay, earlier we used to say that no screen time before 2, but now, you know, the American Academy of Pediatrics, they've also said that 18 months or younger, no screens are still best, but still you can do video chat. So of course, technology has occupied a very important role, but avoid solo use. This is something I would really, really advise for patients, for parents of young children as well as practitioners. Avoid solo use. And even if they have to watch TV, watch at longer distances. Make sure they don't go very close. Take frequent breaks, because now that schooling is happening, okay, now the question is, okay, the whole school is happening now online through technology. What will I do? Nothing can be done. Of course, after the class hours, take frequent breaks and engage them in whatever way that is possible. And so why would this whole gadget addiction takes place? Of course, you know, we all know this dopamine rush that sets in, but what I want to drive is a very important message, especially to all the youngsters listening to this talk right now. Okay, all the optometry students, whenever you start something very fresh, very new, your dopamine, which is a neurotransmitter, it just surges up so high, and that is what gives you the pleasure. Okay, it just tells you, oh, it feels so good. And then you just stay away from the gadget, it just dips in and it wants to go back. Very similar to any other addiction like smoking or alcohol or whatsoever. Then you move on to the tolerance phase, where the dopamine rush doesn't go as much as high as what happened initially, and it would actually go on the reverse side. Okay, it just kind of dips in and goes very low, even though you are still using the same gadget. So whatever pleasure that you were deriving earlier will not actually happen in the long run, and that is when anxiety and depression sets in. Okay, which can happen very quickly within a month, or it can take up to 6 to 8 weeks. But then whenever you start to sense this moments of anxiety and depression, especially with social media, which actually gave you so much pleasure very at the start of using it, you have to think about the whole mechanism that the dopamine is not doing you any favor. It's time to stay away. Okay. So now the thing is, okay, now that we have the whole physical distancing, I would want to use the word physical distancing than social distancing. Now in the world of physical distancing, how do I do these procedures? How do I make sure my binocular vision practice does not suffer? Okay. So of course, it is important. You are not going to stay at home all time. There is going to be increased surge of myopia. Last episode we discussed about digital eye strain, and now you know accommodative spasm. Okay, so all this is going to really come up. And how do we do it? These are some of the tips. We can take it as a separate session also, but this is what this is a small part of the SOP that we wrote for our clinic at Nethralaya. First is, of course, all the basic disinfection guidelines. Please ensure. Generally, I would want, whenever we do BV procedure, before COVID era also, I will tell my clinicians to wipe the prism bar every time after you finish the cover test, okay? And now this has become a standard of care. So you have to follow all your disinfection protocols, 70% isopropyl alcohol or whatever that your organization comes up with. Make sure you use the disinfection protocol. The next thing is a minimum test battery. Don't do the full BV assessment, okay? Go and read this paper. Of course, the presentation is going to be made available. Only 3 procedures. It's going to take you not more than 7 minutes, okay? Only 3 procedures. I've listed it out here. Only stick on to the minimum test battery. It will give you the same result as the full workup, okay? Stick on to it for now until we get back to the whatever normal that we want to get back to. But stick on to minimum procedure that is required. So the role of a senior clinician is very important to take the decision, okay? Next is vision therapy. Whenever you want to prescribe home vision therapy, think about, this vision therapy kit. So what we do is, like in double Ziploc cover, we have this vision therapy kit that's made available. You can make these things available. So whenever you see a patient with convergence issue, they can go buy the kit. Then with the same kit, you can teach the patient what to do, how to do. All the instructions can be only emailed or used, or given as e-instructions. Avoid papers, okay? So cut down all the papers, email it. If the patient doesn't have an email, let them take photo of these instructions and take it home. Avoid using paper copies, okay? That's the second strategy. The best strategy is to use virtual vision therapy to diagnose, provide vision therapy and monitor. We are going to explore this much more detail, okay? For example, this is a snapshot of the binocs where the pre-vision therapy is done. You can do it remotely also, okay? If you have your patients who've already been examined and on vision therapy, you can send a link, they can download it, they can do their assessment, and then you can look at what is the same parameter we discussed, okay? The FODIA status, your near point of accommodation, accommodative facility, convergence status, pre-vision therapy. After the patient does it, post-vision therapy. So patient gets to see. So in this case, again, everything, the near point of the convergence, amplitudes, facility, everything improved with just 10 sessions of therapy. So, again, as I told you, the technology is going to take a key role in managing your patient. So we are seriously exploring all these options of remote diagnosis and remote therapy, at least to begin with, okay? Because that is one way that you can really kickstart your practice and make sure your practice survives and thrives, okay? And when, suppose if there is no other go, sometimes you might get patients where they are not in a position to take any therapy home, and they have to do it under your supervision. If there's no other go, do not take more than 1 patient at a time, okay? Only 1 optometrist, 1 patient inside the room, and use disposable gloves whenever the patient, because in VT, patient will meddle with a lot of things. So patient will have to use gloves, practitioner has to use gloves, and make sure that, you handle all the equipment with high precautions, okay? Again, all this is very temporary, and we'll get out of this soon. The next thing is webinars for patients regarding awareness. and visual hygiene. This is another way to engage your patients. Okay, so we are planning a lot of such stuff. All your existing patients or new patients or anybody who is emailing you, your database, you can organize. For example, parents of children who are already myopic, parents of children who are having progressive myopia, share some important information to kind of bring down their anxiety, because poor parents, they're also very anxious, and awareness about emotional well-being and visual hygiene and things like that, what they can really do. These webinars will help you to stay connected with your patients in whatever ways. Optometrists can really talk about, a lot of visual hygiene aspects. Today also we had a discussion with one of our fellow as how we can actually start doing this. These are some of the tips. I'm not an expert. I'm also going to struggle with all of you in this run to just get back our patients to the normal track. Okay, but I'm just finishing up with this, which is the Forbes survey on predictions on how things are going to change. Among the many predictions, I just took 4 things which are very important for a BVVT practice, which is innovations will flourish. This is the time your creative juices are flowing. Anything that's coming in, use it to your advantage, so that you can become an entrepreneur. You will be more comfortable with technology now, so please make sure you use it to the advantage. Speed will increase. All our speed with computers and technology will increase. Your patient speed will also increase, and collaborations and networking will surge. So these are the very, very positive predictions. Okay, so make sure you just use it, and I really, really wish all of you a very, very happy time ahead practicing binocular vision. And of course, I look at this. This is not what's going to happen now. I'm not going to be using the astronaut ruler touching the patient's forehead. We are not going to do any of these things now. Okay, we are going to change to a new mode of working, and my fantastic team that's always supported me. And before I just stop, just in the chat box, type one thing that you learned today, uh, from this whole webinar. So as you keep doing it, as we usually do this at the end of every webinar, one thing that you will take home from this webinar that you will incorporate or execute, not just learn and keep it here, but then take it to your hands. Okay. And these links will be available to all the optometry students. Resources for setting up your VT practice, business plan for your VT practice, how to bring vision therapy into a primary care optometry practice. Fantastic links. Go look into the links and see how you can start your BVVT practice. Any feedback, please feel free to email Oli or me. My email ID specific for this particular webinar is here.